All right, well, my name is Erin Berkley. I'm a pediatric nurse practitioner. I work with Pediatric Urology at the University of Louisville Physicians downtown office. I started with the practice about 1.5 years ago. I'm a pediatric nurse. Ever since I've been out of nursing school, I've worked as a pediatric nurse, and I'm now starting to work with more of our adult patients. So today I'm going to be talking about biofeedback for pelvic floor retraining, and just talking about urinary incontinence and how we can get better control of urinary and stool incontinence in both children and adults with the biofeedback program. So the first thing is to talk about our objectives. We're going to talk about pelvic floor dysfunction, the things that are included in pelvic floor dysfunction, what makes the pelvic floor dysfunctional. We're also going to talk about, of course, how biofeedback is incorporated to help treat our patients. And we're also going to talk about how to know if you or one of your patients is an appropriate biofeedback candidate. So the pelvic floor consists of bone, muscles, and connective tissue that support the pelvic organs, spine, and pelvic girdle to assist with urinary, defecatory, and sexual function. These functions require relaxation and coordination of the pelvic floor muscles and urinary and anal sphincters to work correctly so that we can correctly void and stool. If these coordinated contractions are not, if they are paradoxical, they can result in various symptoms such as impaired voiding, defecation, pelvic pain, and even as far as sexual dysfunction. Pelvic floor dysfunction is also known as dysfunctional elimination syndrome and pelvic floor dyssynergia, which again just means that the pelvic floor muscles are not working in coordination with the abdominal muscles to allow the sphincters of the urethra and the colon, the rectum, and also the vagina to function the way they were meant to function. The levator ani is divided into 3 parts, and you can see here the levator ani muscles. And in this, we're talking about a woman, obviously. So you can see how these muscles really surround the urethra, vagina, and also the rectum. Again, if these pelvic floor muscles are not able to relax and contract properly, this is when people have problems. It's just another picture of how much these muscles impact these sphincters. So when we're talking about pelvic floor dysfunction, we actually talk about relaxing and non-relaxing pelvic floor dysfunction. Relaxing pelvic floor dysfunction is probably what most of you have heard of in the past, mostly from women who have had babies. We contribute this to aging. And unfortunately, we've kind of thought about this in the past as just a natural part of aging, and it's actually not. There's a lot that we can do to help these patients. So these symptoms result from the weakened pelvic floor muscles. Symptoms include pelvic organ prolapse, urinary incontinence, and also stool incontinence. So in these images, you can see the normal pelvic floor. The muscles are tight. The orifices are actually, the sphincters are controlled by the muscles. In this picture, be this age, childbirth, these muscles will actually start to atrophy. It's just like any other muscle in the body. If you're not using it and strengthening it, you're going to lose it. So you can see how the bladder is tilted, leaning downward. These sphincters are not tight. Vagina and also the rectum here. Non-relaxing pelvic floor dysfunction, we see this. This is mostly what I deal with children in the office, but we can also, this can actually begin in childhood and progress into adulthood if it's never dealt with. So symptoms result from inability to effectively relax the muscles surrounding the urethra, anal sphincter, and the vagina. Symptoms include voiding dysfunction, anorectal dysfunction, sexual dysfunction, and generalized pelvic pain. Unfortunately, whenever a patient goes to their physician with these, or whenever you see patients in your office, it's oftentimes easy to put these off to other things. Again, pregnancy, aging, anxiety from sexual dysfunction. Sometimes we do not go right to pelvic floor dysfunction, and this needs to move to the forefront of our minds when we're evaluating patients. Or if you go to see your physician, these are things to bring up. The symptoms tend to develop slowly and insidiously. For some patients, they may begin in childhood. And again, in childhood, we see this a lot. Kids are holding at school, they're not wanting to go to the bathroom, they're penalized whenever they go to the restroom, so they tend to hold. Or they have long-standing constipation, which is just made worse by pelvic floor dysfunction, and they learn to hold because it's painful. And then they get into a cycle of these problems. So again, there's difficulty evacuating stool or straining with bowel movements because you're not able to relax the pelvic floor muscles and those sphincters stay tight. There's also a sense of incomplete evacuation, bloating, and constipation or bowel symptoms characteristic of the non-relaxing pelvic floor. Again, urinary symptoms, frequency, hesitancy, urgency, pain with urination, bladder pain, and urge incontinence. This can be, again, from a couple of different reasons. Most often because you have that sensation to void because you're never able to really fully empty that bladder because the muscles are so tight. Sexual symptoms, insertional or deep pelvic pain, pelvic ache after intercourse, low back pain radiating to the thighs or groin, and the pelvic pain unrelated to intercourse are also common. It's important to inquire about the range of symptoms that may suggest non-relaxing or hypertonic pelvic floor dysfunction in women who present with bladder, bowel, or sexual concerns. Again, if you're not a provider, something to keep in mind for yourself or your friends or family members that may confide in you and talk about these issues. Just something else to give them to think about to present to their providers. So here you can see this is actually muscle activity. Up here in the normal image, you can see whenever the patient is relaxing to either void, to urinate, or to have a bowel movement, you see this nice relaxation of the pelvic floor muscles. With pelvic floor dysfunction, you actually see a tightening. So there's a paradoxical contraction. The patient actually needs to relax, but their muscles are not able to relax, so they actually contract, and you get the opposite effect. So what is biofeedback? Biofeedback is just a way of retraining our brains. It's a more effective way. We as human beings are visual learners for the most part. We remember things a lot better if we can see it visually rather than just having it read to us or reading it in a book. So biofeedback assisted pelvic floor exercise incorporates the use of electronic or mechanical device to relay visual and or auditory evidence of pelvic floor muscle tone. In our situation, it's visual, what we use in the office. You actually get a visual picture of what your muscles are doing to help you perform the exercises correctly. So in biofeedback, Dr. Kegel, we've all heard of Kegel exercises. Dr. Kegel in 1948 was the first to report the efficacy of pelvic floor muscle exercises in treating urinary incontinence in women. Well, as time went on, we started to realize these aren't that effective. Why aren't they effective? And the problem is that whenever most people are doing Kegel exercises, they're actually using their abdominal muscles. They're not isolating the pelvic floor muscles, which they have to learn to relax to change these symptoms. So researchers started looking at it and saying, what can we do to make this more effective, to make sure patients are doing this correctly? So that's why we added the EMG sensors to be able to have the patient visually look at it on the screen and say, oh, I'm using my pelvic floor, or oh, I'm making a mistake and I'm using my abdominal muscles. This feedback helps to isolate the specific muscles and can assist in motivation by visibly displaying pelvic floor muscle activity and progress. So this is how it works. This is the cycle. So here, your brain sends, we tell, try to pee, try to have a bowel movement. So the brain sends the direction to the pelvic floor muscles. This is actually the monitor, and we use this very rarely in the office. We have kids' pictures, which are much more entertaining, and most of our adults actually like to use those. So it's just, there's actually stickers that go on the stomach and also on the bottom. There's nothing internal. And this is how we see the activity of the muscles. The brain learns the muscular activities through the sense organ, and then this information is sent to the brain, and this is how the Kegel exercises are actually made more effective because you're retraining your brain visually. This is our machine. Here are the patches. and this is what it looks like. And this is where you actually see that top line right there is actually the pelvic floor muscles. The bottom line is the abdominal muscle readout. So you can look at it and actually visualize what you're doing when you're doing these exercises. And here's more pictures. This is, like I said, this is much more entertaining than our adult picture up here, so we rarely use that. We always use the fish, or we use something fun, and it just makes it a lot more interesting. But the way that it works is one of these fish represent the abdominal muscles, the other set represents the pelvic floor muscles, and you actually contract and relax and make these objects move, or up here, make these lines move. So does it work? Yes, it does. This study was actually a literature review of 28 prospective randomized studies published in peer-reviewed journals from 1975 to 2005. And included patients with stress, urge, mixed, incontinence related, and also incontinence related to a radical prostatectomy. Male and female patients were included. There were no pediatric studies that met inclusion criteria. Unfortunately, in pediatrics, we don't have a lot of great studies because people don't want to allow their children to be used in studies. So we have to interpret these as best we can for children for the most part. Summary of the findings was all of the biofeedback groups in the review showed statistically significant symptomatic improvement. The big deal is the overall mean treatment improvement was 72.6%. So that's pretty significant. Biofeedback demonstrated statistically superiority over no treatment at all. Unassisted pelvic muscle exercises, or the Kegels that we've heard so much about. Anticholinergic medications such as oxybutynin, ditropan, Detrol, those types of medications. Placebo, which we all know placebo really isn't a treatment, it's just a sugar pill for the most part. And intravaginal electric stimulation. Another study that was published in Gastroenterology was how effective is this for patients with chronic constipation. So a randomized control study of 109 patients showed they had to be included with severe constipation lasting longer than 12 months, proven inability to relax the pelvic floor muscles, and failure to respond to a 30-day trial of fiber plus laxatives. Enemas or suppositories up to twice a week. The study aim was to compare biofeedback to polyethylene glycol or Miralax plus education. Again, summary of the findings: at 6 months, major improvement was reported by 80% of biofeedback patients versus 22% of the laxative-treated patients. So again, commonly, you think, oh, well, constipation, and it is. It's a large part of our diet. But if you're eating correctly, you're drinking water, you're taking laxatives, things just aren't working. Again, we need to go to the pelvic floor and look and see if you're actually using that correctly. The biofeedback benefits were sustained at 12 and 24 months. There was greater reduction in straining, sensations of incomplete evacuation, laxative use, and abdominal pain reported by the patients in the study. All the biofeedback patients reported improvement in pelvic floor relaxation. 5 biofeedback sessions more effective than continuous laxative use for treating pelvic floor dysfunction. And actually in gastroenterology, which is where the study came from, their recommendation was it needed to be the treatment of choice for constipation associated with pelvic floor dysfunction. The 5 biofeedback sessions, we typically do 6 in our office, is just a standard session for patients. They come in weekly or biweekly for training, and then you go home and do the exercises. Now, it may be more depending on the patient, it may be less. You know, if you've come in for 4 sessions, 4 would be the minimum that we would do. You come in for 4 sessions and you think, I'm doing my exercises at home, things are better. Then we may say, okay, keep up with that and come back if you feel like you need a refresher on these exercises. But 4 to 6 is typical. So here is a graph from this study. This is a comparison of patients who were just treated with laxatives versus patients that were treated with biofeedback. So no patients in the biofeedback group reported that they were worse. The big thing I want to draw your attention to here is that 80% of the patients in the biofeedback group reported a major improvement in their symptoms, compared to only 20% in the laxative-treated group. And in this figure, the big thing I want to draw your attention to, this is the average number of bowel movements that patients said that they had that were accompanied by straining. So again, in the laxative group, we're up here to almost 4. in the biofeedback group were just a little over 1 bowel movement per week that was accompanied by straining, excuse me, post-treatment. This is actually a study of one of our patients. This is one of our little 5-year-olds who came in, and he was having urinary incontinence, frequency, urgency. We had treated him. We had treated his constipation. We had him on a schedule of going to the restroom, and he was still having problems. So this was him initially when he came in. You can see here, this again, is this top line is the pelvic floor muscle activity. This down here is the abdominal floor activity. You can see here, whenever we asked him to contract his pelvic floor muscles, he was also contracting his abdominal muscles, which again, that is the root of pelvic floor dysfunction, is that you're not able to isolate these 2 groups of muscles, and then you end up with the muscles working against each other. This is him at 3 weeks. He's able to keep his abdominal muscle pressures low. He's also able to isolate a pelvic floor contraction and hold it. So this is pretty amazing. This was at 3 weeks that this guy did this. And he came in, he finished all of his sessions with us, and at his follow-up, he was not having any more accidents. He was able to control his urge to urinate, and he was well controlled. Here you can see this is another example of how here with the void, there is increased muscle activity in the pelvic floor muscles as well as the abdominal muscles. In this figure, here's your urge to urinate or your actual bowel movement or voiding. And here you can see this is well controlled. This muscle activity is low. They're able to relax. So this is just helpful just so you can kind of get an idea of how the muscle activity works. So I didn't know if there would be any providers in the audience today, so I went ahead and covered some topics for doctors who may be referring. Some significance that we need to remember is that only 1 out of every 12 patients in the U.S. report incontinence symptoms to their doctors. The average time that a patient waits to report these symptoms is 3 years. So patients on average are living with these symptoms that are very embarrassing. And for the most part, it's either one, because they think this is normal. This is a normal part of aging, and why bring it up? It's just something I have to live with. Or they're embarrassed, so they don't bring it up. The point that we need to remember is that 80% of these patients can either be cured or improved to make them more functional, to make them feel better about themselves, increase their self-esteem. Again, as we talked about, persistent myth is that incontinence is a natural part of aging. Well, you've had kids, you're going to wet your pants. That's not the case. It doesn't have to be the way it is. And incontinence is the leading cause of nursing home admissions. So, again, why would you want a loved one in a nursing home if this is the sole reason that they're going? There are options. The incidence in women who had reported are over at 50%, with pregnancy increasing the likelihood. The incontinence rate in men over 60 has been found to be 10 to 25%. And again, quality of life issues are huge with urinary incontinence. Even if you're wearing pads to control so it's not showing through your pants, you still worry about the scent. You still worry about what people are going to say. Are you going to be sitting next to someone who's going to make a comment? This is a major impact on people's lives. So this is a whole lot of information. The only thing I really want to draw to your attention in this is that this was a study that was a large study. It was a sample based on 30,000 people about the prevalence of lower urinary tract symptoms. And lower urinary tract symptoms are everything that we've been talking about today: urgency, frequency, incontinence. The prevalence rate of at least one symptom was 72.3% for men and 76% for women. And at least 47% and 52% are reporting at least often as having symptoms. For most lower urinary tract symptoms, at least half of the participants were bothered somewhat or more, using a frequency threshold of at least sometimes. So it just tells you how prevalent this is. So if you are a provider, or if you're someone that's having problems with this yourself, some things to think about are talking to your doctor, or have your patients talk to you about what's going on. At least ask. A lot of times we're in there for one specific thing, and you don't think about mentioning this. So it's just good to bring up these points of interest, or if you're a provider, to ask your patients, are you having any problems with incontinence? Are you having any problems using the restroom more frequently? Are you embarrassed by this? Is this something that's affecting your quality of life? Sexual function. Again, this is a big part of our lives. You know, if you're having problems with this, it causes problems in a lot of different areas. So again, talk to your doctor or ask your patients. Again, this is more patient evaluation. We just need to rule out other causes, possible causes for the symptoms. And other things to consider are possibly an ultrasound of the pelvis if it's for pelvic pain, urodynamics. We do all these things in our office, so this is nothing you have to worry about. We can take care of this. And then the cornerstone is referred to pelvic floor physical therapy, which is another term for biofeedback. You may hear it called interchangeably. Okay, so the big thing is the patient must be motivated. The big patient criteria is you have to be motivated, or your patient has to be motivated. We compare it to going to the gym once a week. If you go to the gym once a week and you're eating McDonald's the rest of the week and you're couch potatoing it, you're not doing anything else the rest of the week to do anything with your muscles, same deal. You come into the office and that's like your once a week at the gym, but then you have to go home and do it. So that's the big criteria for this, is you have to work on those muscles to keep them tight and keep them strengthened. So that's our big criteria that we talk to patients extensively about, is if you start this for your best benefit, this is something you're going to have to commit to at home. So advantages of biofeedback: it's non-invasive, it's highly effective for the proper candidates. Unlike pharmaceuticals, there aren't side effects to doing biofeedback, and it promotes patient independence and self-confidence. This is how to contact us. Our pediatric urology office is over in the Gray Street building across from the pavilion, and our adult office is in the HCOC on the 4th floor. So these are, I don't know if you know these physicians, Dr. Ankum, Messer, and Rao, and then Dr. DeGiusta is our pediatric urologist, and is the other nurse practitioner that works in the office with me in pediatrics, and then we also see adult patients for biofeedback also. Our equipment is actually over in this office at Gray Street. So if you're a patient, you would usually start with one of our adult practitioners and then come over and see Ann and I for your actual biofeedback sessions. And Carolyn, who's also she is our urology nurse who actually does the training sessions with you, and she's fantastic. And remember to call your mother and say something nice. Remember, it's your fault she pees a little every time she sneezes. And that's it. So does anyone have any questions about anything we covered today? Questions about therapy, how long what needs to be done before you come in, how to contact us? You all have the brochures there that has all of our contact information.